Our first session this morning is Advancing Milestones through Neuroplasticity. I'm going to read Danielle's bio, and then we will get started. Danielle started practicing as a pediatric occupational therapist in 2010, where she focused on sensory processing dysfunction, autism, and standardized testing. As a traveling OT, she gained experience across settings, including early intervention, schools, outpatient pediatrics, skilled nursing, inpatient psych, acute care, and home health. Danielle observed neuroatypical patterns in kids, such as the presence of primitive reflexes, oculomotor deficiencies, low muscle tone and joint stability, oral overflow, and more. She noticed many of these symptoms overlapped with her adult neurological patients with stroke, TBI, Parkinson's, etc. Danielle wondered if she should be using more brain-based interventions to treat developmental delays. While searching for more effective techniques, she discovered functional neurology. She started training with a team of functional neurologists in Chicago in 2014. It was here where she learned to not just look at developmental milestones and acquiring skills, but also how to assess the nervous system for root causes, dysfunctions, and to train it back into homeostasis. With a new approach to therapy, new techniques, and drastic progress toward goals, it was obvious to Danielle that she had to share these interventions with more clients and professionals. Danielle Nelson opened Brain Bright Therapy in 2017 and launched an OT certification program, CNSI Therapies, with Dr. Ember in 2023. I will now turn it over to Danielle.
Thank you, Erica. Is my mic working? Okay, good. Yeah, sorry for the long bio, but I do like to give background of where I'm coming from and what has my journey been to show up here and talk to you guys. So appreciate you for listening to that. So this slide, we're just going to go ahead and skip right over. I did do a previous early intervention presentation back in September. So I would first like to start with maybe a raise of hands of who saw that presentation. Okay, good. Good. Thank you for being here again, because I do want to build off of that. So the title of this presentation is part 2 to that. I spent a lot of time discussing fight or flight and kind of a safety first approach with treating our clients. And when we show up and we meet them for the first time, keeping in mind that are we showing up in a threatening way to them? Even if we're being very smiley and nice, are we in their space? And making sure that we're acknowledging that behaviors can often be just an instinct or a reaction. So whenever we see that, we're constantly observing how are they responding to me in their space, and do they feel safe? Because we cannot get to learning and reaching higher level developmental milestones if we are not feeling safe. So I wanted to put this in here because I'm not going to be going over as much of that today, but for those of you who didn't see it, the link is here. When you get access to these slides, it is a link, but also you can just type that 2024 Ohio Early Intervention Forum into YouTube and see that, because that's going to have actual exercises that we have found that promote safety. So when you're first showing up with that client, how do you help them feel safe? So there's ways you can do that with your therapeutic use of self, but then there's also exercises to do. So I wanted to put that in there right from the beginning so everybody kind of knew that did not get a chance to see that, how to get access to it and catch up if there's something you do want to see that I fly over in the beginning. Okay, so CNSI stands for Central Nervous System Input. So central nervous system, the brain and the spinal cord, primarily we focus on the brain with CNSI and its input. So it's how can we provide specific input to stimulate quote unquote weak neural pathways. So how do we figure out where the brain is weak and do simple things, simple input to stimulate those weak neural pathways? So that's what we're going to be talking about today from a provider level as well as a parent level. So this is an introduction to that, and providing specific brain input to increase the frequency of firing in weak regions of the brain. So I do want to note that the brain is all electrical energy, right? So that's what we're doing, is trying to increase the frequency of firing within those pathways in those regions of the brain. So CNSI is the approach that we use at Brain Bright Therapy. So if you're looking at the slides and kind of wondering what the difference is between the two, Brain Bright is the clinic that I opened in Toledo, which is an intensive occupational therapy program. So when you hear me talking about the two, those are the difference. We treat a huge range of conditions. I would say the most popular traits are the anxiety, sensory processing, ADHD. That's kind of the biggest thing, and that is from kids all the way through adults. So we see, adolescents trying to figure out what they're going to do next after high school and not having the skills, to parents. They start off bringing their kids to us and they're like, I've always had anxiety and ADHD. There's something I can do about it now. So they, as well as adults. So that could be that same thing, or they're diagnosed, they've had a stroke. They've, have gray matter lesions that they've been diagnosed with. What can I do to be proactive and try to prevent progression? Or how can I live a quality life without this chronic anxiety I've been experiencing, or I have this overwhelming fear come over me at times and I don't know why, and it affects how I am as a parent or a wife, a husband, etc. Okay, so what we're trying to do is really figure out where is the problem actually at within the central nervous system. So we often are trained to look at skills and to look at behavior. But what we're going to talk about today is how is that those behaviors stemming from brain dysfunction or weak neural pathways. And the typical way that we would look at that would be with an MRI or a scan, but those are not very sensitive. So they're not going to show small dysfunctions, right, at a functional level. They're going to show, do I have a brain bleed, right? Some major things. But typically, if somebody with ADHD got an MRI, they're not going to show anything. They're going to get an MRI just to rule out anything. And the neurologist says, nothing was shown on the MRI, right? So what we're trying to do is determine where at a functional level can we strengthen the brain, okay? And I do want to put out there that I'm very open. So if anything comes up, or if I'm talking about something and you want clarification, raise your hand, holler it out. I'm happy to do that. So feel free. Just to review, neuroscientists have learned a great deal in the past few decades. So there was a lot of money put into brain mapping. So this is where this is coming from, is there's, within the last couple decades, there's been so much research done, and neuroscientists have learned a ton. So how can we pull from that research and figure out, how does this apply to what we do as, therapists, intervention specialists, parents, all of that, when we learn more about the central nervous system? Okay, so this is a little bit of the why I am passionate about this and why I think we need to shake up our approaches a little bit, is because 1 out of 5 kids have developmental disabilities. 1 out of 9 have ADHD, 1 out of 13 have asthma, 1 out of 36 have autism. Okay, and the biggest kicker for me that I think about every day is that the second leading cause of death in kids is suicide. Okay, so our kids are struggling, right? And those kids that we see, even as early intervention age, 0 to 3, right? They're going to grow up, right? They're going to be teenagers. And how do we show up in a way that is supportive to them and they feel safe from an early spot first? And then how can we rewire their brain to be more balanced and organized so they feel confident walking into life as they get older, and that they can take on these things and they're not overwhelmed? Okay, another thing here is that 90% of our nation's 3.8 trillion per year healthcare costs is attributed to chronic disease and mental health conditions. Okay, so that's not the acute heart attack, stroke, anything that's acute and in the hospital and then you go home. These are chronic conditions, right? So this is autoimmune conditions. These are the things that we see every day in our family, in our friends that we're dealing with, anxiety, ADHD. So that is 90% of our healthcare costs. So how can we treat it differently and more efficiently? Okay, so if we continue on this trajectory, it is estimated that 1 in 2 kids will be diagnosed with autism in 2050 if we stay on this same rising trajectory. Okay, so we have to start thinking about why and what can we do about it when we're here? How can we help to heal our kids? Because there is actual research that shows that we can heal autism. It takes time. It takes a lot of time and a lot of effort, but we can do it. Okay, so I know because this is the early intervention track, I also wanted to bring this slide in because I know as early intervention providers, you are seeing more drug exposure and withdrawal symptoms. But also I really wanted to bring this slide in again and talk about it is because the CNS is connected to all of our symptoms, right? So the hyperirritability, high-pitched crying, jitterness, tremors, all of those things that we look at as symptoms are connected to the function of the brain. So same with autonomic, right? So if we see their heart rate, so high heart rate, if you see sweating, yawning, nasal stiffness, this is the autonomic nervous system. It's still the nervous system. Okay, so GI symptoms, poor feeding, vomiting, diarrhea. So I really just wanted to take a minute with this to kind of say, yes, everything is increasing. We need to look at things a little bit differently, but also everything comes back to the brain. Okay. So even if we talk about muscles, low tone, muscle tightness could be compensating for a fear of falling. So we tend to think of fear of falling in adults and older adults, but kids actually have it too, and kids with autism especially. When they're not grounded in where they are in space and they feel like they're falling, they do different things to try to compensate for that. So when we're looking at how their position and their posture, it often can be related to how the brain is processing where they are in space, where they are moving, and are they secure or not. So coordination, clumsiness, anxiety, hyperactivity, inattentiveness, and behavior can all be tracked back to the brain. Okay, so I talked about this before. How do we treat the brain, right? Number one, it's acknowledging that a lot of behaviors are instincts for the kids that we work with. For adults as well, right? If all of a sudden they're having an emotional reaction, you're talking to a coworker and we can say, ooh, their fight or flight has been triggered. Their protective response has been triggered right there. And the more that we can think about it from that state, the more we can communicate and have empathy and know how to meet that person where they are. After that, then we're kind of, how do we exercise the brain and increase that frequency of firing? Okay, so things to keep in mind about fight or flight and how the brain kind of works together. Because again, over on your right-hand column there, overstimulation, defensiveness, irritability, strong emotional reactions, mental fatigue, insomnia. We might think about those as all separate symptoms that are not interconnected. However, those are all symptoms of somebody that's in chronic fight or flight. Okay, so a nervous system that's in this state all the time. So if I'm in the woods going for a hike and I hear a loud noise in the bush, there's a big animal over there, right? I'm going to probably stop, look, listen with all of my senses. And I'm not going to be able to, if my friend's talking to me over here, I'm not going to be able to listen because I'm in fight or flight, because there is danger and there is potentially a threat to my survival. So my instincts, right, all of what's hardwired within me to keep me alive is not allowing me to tune into that human voice, is going to hear everything, see everything. And if we're living this way right now in this presentation, if you are living this way, it's hard for you to maybe tune out that person over there making a noise with their foot that they don't notice, because you are tuned into everything, because it's survival and it might be dangerous, right? If there's clock ticking over there, how can I tune that out? If somebody's walking in the hallway, I'm paying attention to everything in my environment to see if it's a threat to my survival. So you can see how that sounds like sensory processing, overstimulation, ADHD, right? So this is often where most of the clients that we work with are living when they come in, and this is step one, trying to activate their parasympathetic rest and digest, make sure they feel safe, and then what kind of exercises can we do to work on vestibular and where are we in space and proprioception and all of those things. Okay, so another thing with being in chronic fight or flight is that our frontal lobe actually turns off. It's a survival mechanism because remember, our brain is electrical energy, but it has a metabolic capacity where every neuron only has so much energy to give, right? So when we only have so much energy to give and there's a threat to our survival, all that energy is going to survival. It's not going to, what am I going to do today? And how do I plan this out? And how should I prioritize this? What should I start first? Okay, let's go ahead and start that. And then I'll do this next. We'll finish this first. And oh yeah, I got to do this, but wait, impulse control. Let's not do that yet. Let's finish this first and then go on to that, right? So that's executive functioning. That is planning. That is how we start a task, work through it to completion and get it done. But that area of the brain turns off in chronic fight or flight. So we can't access it. So unless we're addressing that, we're not going to be able to treat impulse control. Okay, so this is a review of what you can do to try to help with that and having somebody feel safe, right? So limit talking, low lighting, sit in their space, parallel play. You're not walking right in, asking them to do something or doing hand over hand to have them do bilateral coordination, right? You're letting them know that you are not a threat to their safety first. And usually what I like to do is just sit and allow them to come to me. Once they come to me, now the door is at least cracked. And now they feel like I am safe enough, and that gives me indication that I can possibly try to engage with them. The physical exercise piece is what you can find on Brain Bright Therapy's YouTube channel, and that is also in that previous presentation. So I'm not going to go through each one of these exercises today because there's the how do we increase the frequency of firing and build neural pathways is what I want to focus on today. But I wanted to let you know that it's there if you wanted to go back and look at it. Okay, so safety and rapport is established, right? They feel safe with you. Maybe they're not out of fight or flight. They still live in chronic fight flight, but they see you as a safe person. How do we start to assess their nervous system and provide input exercises to try to rewire their brain so that they have a better sense of where they are in space? Right? So I keep saying that term, where are we in space? So I do want to take a second to clarify that is, if I remember I said like muscle tone and different things can be compensating for fear of not knowing where we are, right? So if that's the case, if I put my feet together and I close my eyes and I'm swaying like this, I do not know where I am in space with my other systems, right? My eyes are really dictating that. And if I take away my vision, all those other systems that tell me don't know what's going on, right? And if I don't know where I am, because the brain's job, the brain wants to stay upright at all times. So if we're swaying, it's because we think that we're falling. So if I'm swaying backwards, it's because my brain thinks I'm falling forwards and they're trying to correct it. Like, don't fall, okay? So if that's happening, how safe do you think I'm going to feel internally? Not consciously, but in those deep parts of my brain. If 3 out of 5 of my systems that tell me where I am in space are saying that I'm falling, how safe am I? No, I need to be vigilant. I need to pay attention. I need to access all of these systems, right? So it's a reason, it's part of why people can be in chronic fight or flight. So what we're going to do is try to do a brain assessment. And so with you guys, I'm going to talk about that in a basic way. And with CNSI certifications for OT, we get really deep. And so I'll kind of review that a little bit. But I want to start with you guys of just looking at the right and left hemispheres, looking at eye positioning, looking at what area of the cortex we want to work on and that vestibular processing. And then how can we do exercises that are most likely not going to hurt anything, right? They'll be good for everybody, and they're going to stimulate balance in our brain and homeostasis, because that's what our brain wants, is balance and homeostasis and everything kind of working together and communicating back and forth. Okay. So this is, some of these things are a little bit overgeneralized, but I really like to cover this because this is where my assessment starts. When a client comes into our office, it often starts with intake that I have from their forms that they filled out before they came in that I'm reviewing, their symptoms checklist, and I'm getting a feel for what is their personality like, and is this client more left brain dominant or more right brain dominant? Okay. And one thing to point out here is that it might irritate some of you that the right brain is on the left side of the slide, but that's intentional because your client sitting across from you, that is going to be their right side of their brain. Okay, so if we start talking about directional things and doing certain things in certain directions, because let's say the right side of their brain is weaker, so we're going to do lots of stuff with their left arm and left leg, we have to remember that their left is over there. Okay. So left brain dominant, right? That's our logical, concrete thinkers. They like to analyze things. They like things to be in order. They like their routine. Our right brain thinkers are our abstract, creative ones, right? Are those imaginative kids that can make up stories and do all kinds of things, right? And so this isn't always exact, but it's a really good place to start. When you try to think of, you know, our kids on the spectrum, they're almost always left brain heavy and their right brain's right down here, and there's an imbalance. And then the brain cannot, it's dysfunction because it can't communicate, because this side of the brain needs to come up to be able to go back and forth and bounce back and forth. Okay. So again, creating homeostasis. A person without symptoms has a balanced nervous system. They're living in equilibrium. So sometimes we might be more left brain where we got to come in and we got to get stuff done. And other times I can go and practice my art, you know, whatever that is. And when I'm doing both of those things in my life, that's when I feel good. That's when I'm in balance, right? And if we are stuck in, I like to use the teeter-totter reference where I am super creative and, well, it would be more this way, but I'm super creative and I do really good art, but my left brain, you know, I'm just not, I can't get my things done. I can't start something and work through it and stay, then I'm going to have symptoms in some way, right? Same thing if I'm just over linear and logical and I'm excelling at work, but I'm missing out on some joy in life and laughter, and I'm missing some jokes and some sarcasm and taking life a little lighter, right? So again, this is a simplification of a lot of complex neurology, but it usually pairs up, okay? So this is CNSI, our first course of certification. We cover all of this, and it's we do all of the exams. We learn how to assess these regions of the brain and then how to do exercises to increase the frequency of firing in that region of the brain. Okay, so you don't need to learn all of this today, but just to get a feel for how many exams you can do that we have looked at that test a region of the brain, and that these research studies, a lot of them have been done with fMRI machines and different things like that, of now we know this to be true. And then what kinds of little exercises can we do that have also been shown to strengthen that weak region of the brain? Okay. So this is just kind of for your knowledge, and if you're interested, on our website, our resource page does have all of the literature that we used for all of our exams and everything that we'll be going over. Okay, so the cerebellum is the first area of the brain that I want to talk about today, which is my balance keeps getting worse. So it's balance, slurred speech, right? Low tone is the biggest one here, right? So a lot of us as practitioners are trained to see the low tone, the floppiness, the joint instability when they're grasping and with their fine motor skills. And that is tied back to the cerebellum, right? So if we see a kid with low tone, we know it's pretty hard to improve those fine motor skills, especially if they're really low tone, right? So even if our goals are functional of, being able to zip up their coat, being able to ride a bike, or whatever it is that maybe a parent identifies as a functional goal that we're working on, that skill acquisition, we can still come back to the brain and say, okay, now what is hindering them from successfully reaching this milestone independently? And how can we stimulate these regions of the brain? So even though the goal might be for zipping their coat, we know they're low tone. So our treatment plan might be cerebellar exercises, right? And how do we do that? We can do finger to nose games. We can stand heel to toe is a really good one. And the foot and back is actually the side that we're using more here. So if I try to have a kid stand on one foot and they're on their left foot and they're going like this all over the place, and then they stand on their right foot and they're pretty good, maybe just a little bit, that's an exam to me that's saying this left cerebellum might be weaker than the right. And that adds up because everything, almost all motor, flows through the cerebellum, it's this part back here, and then crosses over to the cortex, right? So that same person who maybe is on the spectrum that is really logical and linear, the fact that their balance is worse on their left makes sense because also their right cortex is weaker, okay? So that's starting to look at all of our motor and physical exercises. And I wanted to bring up too that I think we all know that physical exercise is good, right, for everybody, but especially for kids, and how we used to go out and play and climb and, climb trees and do all these things, and kids don't really do that anymore. And so the cerebellum is one of the ways that I really like to highlight how encouraging that can really help the development, because all motor goes through the cerebellum first and then up. And then you have all of that motor planning and stuff, which is using that frontal lobe, so motor planning is actually the frontal lobe, the same area of the brain that's executive functioning and getting things done. So the more kids do that when they're young, the more they're stimulating that frontal lobe for skills when they get older. Okay. The parietal lobe is another area that I wanted to talk about because it is highly tied to where are we in space, tactile processing, body awareness, spatial relationships and awareness. So there's some exams that we do. So pursuits are slow eye movements following a target. So a lot of people call that tracking, visual tracking. Point localization is when I were to touch somebody with their eyes closed and they would have to touch where I touch. Graphisthesia is drawing something on preferably their hand. So if they know their shapes, you can draw a shape in their hand with their eyes closed and they tell you what shape it is. And stereognosis is putting something familiar that they know in their hand and they tell you what it is. So you can see how this is all kind of tactile processing, proprioception, where are we in space? So it's working on that. So cerebellum is all like, think of ankles and foot and different stuff, all those muscles sending feedback. And then this is more tactile processing. And so in a little bit, I have a slide that's going to go over the main areas of how we know where we are in space. And this is a big one. So you can play those games, those things that I just mentioned as exams. Those can be used as games with the kids to facilitate those neural pathways, right? So if this is a kid that really lacks body awareness and is bumping into things all the time and all over the place, right? We can just from around the house, their favorite car or their little toy that they have there. You know, we close their eyes or even use a little blindfold because the sage likes to peek, right? And put it in their hand and say, okay, what is it? And we can downgrade the task too, which means we can say, we can put all three of those things in front of them. And so they can see them first. And then you say, which one is in there? Or can you say, is it hard? Is it soft? How can you describe it? And really tap into those sensations are all going to be firing up that same neural pathway. Okay, so we do about 50 neuro exams during an OT evaluation, and then we're very sensitive with those findings. So if one of the tests for the cerebellum is finger to nose, so it's just like this, touching. And if this right hand touches tip to tip, and this one is off a little bit, even that subtlety, even though they touch their nose, I'm plotting that on my brain map because it tells me something, that that left cerebellum was weaker than the right, okay? And then maybe that's significant. Maybe it means something, maybe it doesn't, but I'm going to plot it down. And then when you look at this brain map, you can see that there's a pattern. Oh, I have 5 tests for my left cerebellum saying that the left cerebellum is weak. And let's pretend I had 1 test for the right cerebellum. Now that's not really significant. That doesn't mean that there's a functional difference there, that I want to exercise that region of the brain. So that's what we do, is we do all of these neuro exams. We plot all of our findings on a brain map and say, where are the patterns? And where is the weakness in the brain? And once I see the weakness, what exercises can I do to stimulate those weak regions of the brain? Okay, so those slides before, I was talking about more the higher level cortex. I wanted to just kind of take a minute to discuss the significance of the brain stem, okay? So the brain stem is our foundation of our brain, and it's a lot of our primitive and automatic functions, okay? So the things that we don't think about that are just reactive. Almost everything travels through the brainstem to get to the cortex and then goes back down through the brainstem to get out. So if I want to, reach to pick up my clicker or do whatever, that information is traveling in and out of my brainstem. A simple tongue movement is going to go through the brainstem into the motor cortex and then back down to move my tongue, okay? So I just take a minute for that to sink in, because if we're talking about a speech delay, right? What's all going on in a speech delay? Is it really the language centers of the left temporal lobe, which is primarily where our language centers are, where it's receptive and expressive language? Or is there a motor component involved? And it's really the motor and the cerebellum and, being able to put our mouth and our tongue and coordinate those movements in that way. Okay, so stay with me on this slide. But this is if you were looking at a brain kind of cut like this, right? So those little, they're called semicircular canals off to the side there. Those are your peripheral vestibular system, right? So that is your ear. And inside there are canals that when I move my head, fluid, crystals, hair follicles flow along the circle and tell my brain where I am turning and where I am going, okay? So that's the ear. And then that information gets sent to the brainstem and then up and crosses into the cortex, okay? So the reason why I wanted to include this slide is to say that there's lots of different places where vestibular happens, as well as when I first started out in OT, an outpatient peds clinic, I learned that vestibular was movement, any movement, getting on a swing, getting on a scooter board. And when I started training with functional neurologists, then I learned, oh wait, vestibular is the ear, it's head rotation, it's ocular movements. I think we need to know that as OTs and as practitioners. Just like if somebody has vertigo, I don't know if anybody knows anybody that's gone to vestibular rehab for vertigo, but they do exercises like this, right? So they are working on the vestibular ocular reflex and doing vestibular exercises with head movements. So this is the slide that shows that, as this is again one of those systems, like most of them, that need balance to function, right? So we'll say when I'm sitting straight like this, my ears are here. When I turn my head, it goes like this. This side activates, this side inhibits and shuts down. So both sides have to be working together to get accurate information to the brain about where we are in space and where we are moving. Okay. So I am an occupational therapist, right? So sensory integration is where it started for me, and sensory processing disorder, and learning about Jean Ayres, who is the founder of sensory integration. And she was guided by the principle that intersensory integration is foundational to function. Okay. Dysfunction in sensory integration leads to difficulties in development, learning, and emotional regulation. Therefore, children with sensory processing deficits may find it challenging to regulate their response to everyday situations. Dressing, playing, mealtime, social, right? So it's all of our behaviors, right? I think most of us as providers understand sensory processing at this point. But what I'm trying to say is, now we know more about vestibular and proprioception. We can go beyond getting on a swing and doing heavy work, even though those things are great. And we still teach all of our parents about a sensory diet and different things like loading up the toy grocery cart at home with real canned foods to push around, putting ankle weights on them because they love it and it grounds them, right? Pushing the laundry basket around, getting a swing in their house. So a sensory diet is still very helpful to help them get regulated and know how your child responds to different kinds of input. But as practitioners, can we also learn more about how to rewire those systems so that we don't need as much of a sensory diet? Okay, so this is the key to everything, knowing where we are in space. Okay, so this is how we feel safe. It's the very primary thing that we need to feel safe, get out of fight or flight. We find that usually 90 to 95% of our clients that come in the door with anxiety have a vestibular dysfunction, have problems with knowing where they are in space. There's also research that shows that anxiety in kids increases 500% if there's a vestibular dysfunction. Okay, so vision, right? That's what I talked about before. When I put my feet together and I close my eyes, I'm taking away vision, but that's one of the main ways we know where we are. Vestibular, now you know about those semicircular canals and how that information gets sent up. Proprioception, the parietal lobe, we talked about that. After it goes to the ears, that's where it goes. Brainstem, parietal lobe, okay? So we need all of these, the cerebellum, and there's this area called the superior colliculus. We need all of these systems functioning and telling the brain accurate information to have this sense. So that's what we do, is really try to assess these different regions and figure out where is the breakdown and how can we, again, reorganize it and re-stimulate it so that our clients can go, ah, here I am, okay? All right, so eye positioning is the first way that I want to teach you guys to look at the brain stem and to try to stimulate those weak regions of the brain, okay? Because the eyes have the most receptors to the brain, okay? The eyes tell us a story of the brain stem. So a lot of the times we look at somebody whose eye is turning inwards like this, and we think, oh, wow, this muscle over here that pulls their eye out must be weak. It must be a weak muscle. That is true, but why is that muscle weak? Because that cranial nerve that innervates that muscle is weak. Why is that cranial nerve weak? Where does that come from? Is it coming from the mesencephalon, the pons? You know, where is it coming from in the brainstem? What region of the brainstem is weak that's causing that cranial nerve and that muscle to be weak, right? And as long as that eye is turning in, now our vision is also distorted of where we are in space. Okay, so looking at that, because that cranial nerve, that same cranial nerve that's weak, could be tied to that same area of the brainstem that processes vestibular input from this ear, right? So it's all kind of tied together. And why is that important? Is because it can also be so easy. Like, it's common sense applies. The complex neurology of this stuff lines up that 9 out of 10 times common sense will apply that if this eye turns in, set up the environment over here and have them look over here. Because you're going to not just try to strengthen that muscle, but stimulate that neural pathway to that weak region of the brain. Yeah. Ooh, it's a whole different ballgame. Because we can no longer really do that movement. You know, they're not using this muscle, because when we do exercises like they're pulling it out over here, we're activating that muscle, which is sending information to that area of the brain, right? Just like if I do a bicep curl over and over again, I'm going to strengthen my bicep. But when they surgically repair it, now they've cut it, tightened it, and they can't really activate it in the same way and provide that same neural input. So we typically try to get people to avoid surgery, but after they've done it, there's a lot of guessing work because it distorts our exams as well. So it's much, much harder after a surgery. And some kids need it, you know, sometimes we try and we can't get it to turn on. And so cosmetically, the family decides to go that route. Do you recommend patching them? Depends on the kid. So yes, I'm not opposed to patching because you're stimulating, right? But also the end goal is for accommodation and for both eyes to be working together and creating the picture. So patching alone is not the whole answer, but sometimes we do it when, especially when an eye is, not usually for when an eye is just sitting in farther, but when an eye is suppressed. So when they really have a strong dominant eye and we can't get them to converge and kind of work together, we might patch the stronger eye to say, okay, turn on. It's time for you to activate here. And then once we get it turned on and stimulated, then we take the patch off and say, okay, now let's see if we can get both of them working together in the team. Okay. So yeah, the main objective of this slide is to say, if a client is looking at you and you notice that this eye is here and this eye is here, it means something. Okay, so you can easily coach a family, because what if they're sitting at their dining room table always being fed over here? We are facilitating weakness. Okay, what if we just switch to the opposite side of the table and they're looking over here at mom? If we start that young, if we start that at 6 months old, it can change. The power in that can just change the trajectory, right? So same idea if they're sitting in like, hopefully not a bouncer seat all day, but wherever they hang out, right? Like, where are they looking, right? And what are they, what is their position during the day? Maybe they're nursing still and mom always nurses them here first, and they're always looking this way and their left eye is coming in looking at mom, trying to get mom. And we need to coach mom into starting on the right and spending more time on the right. Okay, so there's all different kinds of things we can do if we just get observant and trust our observations, that no, that's there and it means something, and let's just go with the common sense of they tend to sit like this, so let's direct them like this. Okay. Okay, so this is where we start getting into brainstem and vestibular exercises. So we have no, no's, and yes, yeses. That's what we call them because it's easier. It's technically a form of a vestibular ocular reflex. So vestibular, ocular, right? When I turn my head like this and my eyes stay looking over here, right? I don't have to think about that. That's not something where I'm saying, oh, I really need, I mean, maybe just now I was because I didn't want to mess up. But normally it's just something, if I came over to you and I turned your head, your eyes should stay on me. My eyes should not drift with my head over here unless I heard something and I'm trying to figure out what it is. That reflex is happening all the time. So as I'm sitting here and presenting to you guys, I'm using that reflex, right? And that's what builds our vestibular system and where we are in space, okay? So if we have a client that does not have a strong sense of where they are in space, we can use this reflex to our advantage. We can say, one of my favorite things is just putting a sticker on my nose and playing while I'm playing with the kid. And instantly, usually they look at me like, why do you have a sticker on your nose? And then so I get that gaze fixation. They're looking at me and I'm just grabbing their head and I'm going ding, 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 ding. And that's it, shaking their head no and keeping their eyes. And usually they're trying to reach and be like, hey, give me that sticker, you know? So it's a way to help them build. And what we're trying to do is be in midline with them. That is an important thing because if we're sitting over here and I'm shaking their head no and they're looking over here, what's happening to their eyes? Now they're doing this. It's not that balance that we're going for. Remember, homeostasis, equilibrium, balance. We want everything to be even and working together. We want these ears to be playing a game like this and get familiar with how to do that. Okay. So those no-nos, this is my goal as practitioners, that as much as we know about sensory integration and swings and heavy work, that we all know about no-nos and yes-yeses, because it can be so powerful. And even like when we are on a swing, making sure we have an ocular component to it, right? If we're really trying to rewire. It's a different sort of input. It's not as powerful vestibular input, but at least we're using those different senses together, right? And reaching and doing those things. So like I said, this can be passive, right? Like I said, I can reach over and I can do it for them. Or it can be active. So if you have, you know, close to a 3-year-old, and I do keep talking in early intervention, right? This is early intervention track, but we do this across the board with all of our patients, that you can have them put something on the wall, or, you know, we have even dot sheets, which is like dots that we send home for their home exercise program, where they're just looking at it and shaking their head. Okay. And maybe this eye turns in, so they're looking at the dot over here and shaking their head, right? So they're rewiring that. Okay, so the goal here, like I said, is midline, equal directions each way, and you never want to go more than 45 degrees, right? So 90 is a full angle, 45 is half, 45 is a lot. Even if you just did like 15, 30 degrees, there's power in that. So if you try to do it with them and you take their head all the way over here, that was probably a little too much, and they were like, whoa, I don't like that. Right? So next time, maybe go at it and just do a small little, I call them little micro rotations. Okay. It doesn't have to be much for there to be a lot of work involved. 2 to 6 reps. So meaning a 1, 2 could be good and could be great for like that 1-year-old, right? But if you can get up to 6, I wouldn't do more than 6. Okay. But you can do it over multiple times during a session with them. You can do it 3 times while you're at their house for 45 minutes or whatever during play. They're playing with something and you're able to get them up here and looking at it, and then they're looking at you, and then you're 1, 2, 3, boom. Okay. This is just a picture of somebody doing the no-nos in a neuro rehab clinic. Gaze fixation. So this is another exercise. Let me check the time. Okay. Gaze fixation is where we are just looking at something briefly for a period of time. Okay, so we do need a gaze fixation for the VOR. We need it for eye contact. We need it for learning, right? But there's a lot of power in gaze fixation. There's reasons why kids can't do that. Okay, so that's also just an exercise. If you just hold up a toy in midline in the middle of their body that they like for 2 seconds, and you're getting, especially that kid that's all like this, if they're looking at it for 1, 2, 3, that's an exercise. That's stimulating the same region of the brainstem that processes vestibular input. Okay, so it's very simple things that you can incorporate into a play-based session that can really encourage those regions of the brain. So we do this, I mean, you could do this up to 10 times in a session, right? If it's only 2 seconds at a time. But we like to play games too where we count and they're trying to beat the record, right? How long can they look at it? Or sometimes if they get to, however they count to, like maybe they did 1, 2, 3, that's 3 minutes of their break time. And then the timer goes off and then we come back and do therapist choice or something like that, to where we're motivating them to try to do it longer. Okay, convergence is the next one. So again, you're having to fixate on something, but convergence now is the eyes converging in, and divergence is the eyes going out. Okay, so this exercise is highly related to the most primitive area of our brainstem, which also correlates with dopamine regulation. So it can be an exercise that people really don't like and they back away. So if you see that, again, common sense applies, that's too much for this. Maybe stay with gaze fixation or try to start farther away. You got too close to them and it was too hard. Start farther away or start here and move backwards. So we have different strings in our office where we can move beads and we can exercise that. But that's not just about visual skills. That's not just about the eyes working together for reading, although it can help with that. Like I said, it also plays a huge role in dopamine and fueling. If we don't have enough dopamine to fuel our frontal lobe, we often need to stimulate this region of the brain to get to our long-term goals of executive functionings, to follow a 2-step direction. Okay. So here is just a picture of, on the far left there, how his right eye was converging, but his left eye was not able to, right? So then that next picture right next to it is when he is fully converging in. And then the picture to the right is part of the treatment. So after 24 hours, what that left eye looked like. It moved from out here to here, but wasn't quite here yet, right? So we're trying to, and this is again part of at a neuro clinic, a neuro rehab clinic. So sometimes they treat concussions, sometimes they treat professional athletes, are now using this type of training, brain training. So they're doing all different kinds of exercises and timing, visual games, proprioception, where are we in space? This has now become the new like athletic training for the advanced professional athletes. So because we know the neurology behind it now, right? We know, so I've trained a woman in Chicago to improve her tennis game with these types of things just because she wanted to and we could, right? So there's, once you understand how the brain works and, you know, if she was trying to watch that ball come in and she was losing it and that's why that swing was off, how do I analyze what area of the brain is responsible for that movement at that direction? And then how do I stimulate that region of the brain? Okay, so this is just, again, reiterating the caution with convergence. You can see hyperactivity or behavior from this because it was too much, too powerful. It was something was coming at them. It can activate that fight or flight that it's threatening. So listen to that. Just always listen to your client and say, okay, I got too close. Next time I'm going to try starting farther back and stopping farther away, or I'm going to try to move outwards instead of inwards. Okay, this is a video that I wanted to put in there because you will get access to these slides. It's just kind of a fun video that talks about the power of the eye movements and neurology and the neuroscience behind it. And it has a lot of animations and examples. This is where I did want you guys to try to play around with gaze fixation in the VOR. Let me see on time. I always run late. I have 2 minutes. So that is something I'll have you guys do when you leave, right? When you're reviewing our slides, of just actually try it on yourself before you try to do it with other people. Try it on family members, right? Ask them, how does that feel? You'll find that some family members really don't like some of these, right? And there's a reason why. It doesn't mean that there's a functional significance to it, right? It might not be causing symptoms, right? But there's still a reason why. And when we do have symptoms, we can use this information to reduce symptoms, okay? So really quick, I'm going to skim over what causes brain dysfunction. Okay, so there's a lot of research now in terms of there are neurological toxins everywhere in our modern environment, from our food and our water, our carpet, hair, skin products, detergents, and plastics, right? So just when we're talking about those statistics going up and up and up, we're also we're figuring out how to better treat them with neuro rehab, but then also how is it starting and how can we prevent it from continuing to rise in the direction that it is. So in a study, 10 newborns, on average, 200 industrial chemicals and pollutants were found in their system. And that's also in the placenta, in the cord, all of that. So this is 180 cause cancer, 217 are toxic to the brain and nervous system, and 208 cause birth defects and abnormal development in animals. Okay, so this is what the research is finding right now. And so when we talk about why are those statistics going up, and people ask the question, is it really going up, or are we just paying more attention and diagnosing more? My answer to that is I've sit in classrooms and I see that there's not just one kid that can't sit still, that's quote unquote a class clown. There might be 8 in a classroom now. It's real. I see the kids that want to be good kids and they just cannot make their body do what they want to do. So these are just a picture of farming, pesticides being sprayed, just so you know, like why is this happening? In part, it's because this is a neurological toxin. All surrounding us and everything, right? Lead pipes. This is where a diagram from Beth Lambert of epidemic answers. So they're saying that these childhood conditions, the rise in allergies and eczema and everything, there's an epidemic to it. It's at an alarming rate of increasing. And so they're studying the whys of it. And so it's not just what we're exposed to in our lifetime, it's also what our mom was exposed to that's being passed down to the baby, and what her mom was exposed to that got passed down to her. So it's generational, right? And like I said, it's in the placenta and the cord blood, right? So we're transferring it, and then it's compounding over years. And then we have exposure in our environment as well, and that exposure is continuing to increase. So everything that we're exposed to is safe for that individual thing. But if we're getting it here and there and there and there and here and there and there and there and there, and now it's no longer safe for us that we can detox and get rid of our body. It's staying in there and causing problems. So there's lots of different things that add to it. It's not just one that are disrupting our microbiome, our gut barrier, leading to inflammation and transfer to brain tissue, causing neuroinflammation. Okay, so that is something that's outside of my scope as an OT, but that I have learned, and I always want to share with people that that's part of the picture here, and trying to create a model with health coaches and functional medicine, neuro rehab, and integrative practitioners that can view this and help the body detox from things, help provide the nutrients that we're missing, help promote cellular health to really, because then we can really kind of grow the brain and rewire it, and then leave feeling balanced and no longer having the symptoms. So thank you all very much. I appreciate it. Good. I didn't do.
Thank you, Danielle. I do want